Good morning, ladies and gentlemen. We have this topic this morning, left main and multi-vessel, updated practice and new concept. My name is David Taggart. I'm from the University of Oxford in the UK. I'm very pleased and honoured to chair the session with Dr. S.J. Park and Dr. Patrick Serruys, who's currently at another presentation, so he should be joining us quite shortly. And I have a delight to say we have an expert group of panelists who will all make important contributions. And our first talk this morning is from the very esteemed Dr. Gregg Stone, Left Main and Multi-Vessel Revascularization 2025, Updated Guidelines and Beyond. Dr. Stone, thank you.
All right, well, thank you very much. Let me get my slides up here. You're working? Okay, so I'm going to give you kind of an overview of where we are, and I think you'll see what the remaining challenges are. So what do the most recent guidelines say about revascularization, that's PCI or CABG, for left main and multi-vessel disease? And I'm going to focus on the 2023 guidelines from the United States. You can see this is from about 6 different organizations, including the AHA and the ACC. And this is going to focus on chronic coronary syndromes, just because in 8 minutes I can't also cover acute coronary syndromes. And there is a 2024 guideline from the European Society of Cardiology, but for once the US guidelines are simpler and more straightforward, and they pretty much say the same thing. So, first of all, for all patients, they give a Class 1A level of recommendation for patients with lifestyle-limiting angina and on guideline-directed medical therapy that revascularization is recommended to improve symptoms. So that's just general overview. PCI or CABG improves symptoms if you're still having angina. Then they give a Class 2A level of recommendation with Class B non-randomized data that if you're a poor candidate for surgery, then it's reasonable to choose PCI over CABG. Well, that's kind of self-evident. Now they go into left main disease, okay? And for left main disease, they give a Class 1 level of evidence B recommendation that if you have significant left main involvement with high complexity CAD, CABG is recommended in preference to PCI to improve survival. So survival for complex left main cases. There's a Class 2A recommendation that if you have left main disease and if you think you can get equivalent revascularization with PCI compared with CABG, then PCI is reasonable to improve survival, and a Class 2B recommendation suggesting that if you have diabetes and left main with low or intermediate complexity CAD, that PCI can be considered an alternative to CABG to reduce MACE. So what's the evidence underlying these? Well, first of all, and then we've got multi-vessel disease recommendations. So first I'll give you the evidence, the guidelines, then we'll go over the evidence. So multi-vessel disease. We have a Class 2A recommendation that if you've got multi-vessel disease, appropriate for PCI or CABG, revascularization is reasonable to reduce cardiovascular events, such as spontaneous MI, unplanned urgent revasc, or cardiac death. They don't talk about all-cause death because the most recent ischemia trial did not show a difference with revascularization in all-cause death, but it did with cardiac death as well as spontaneous MI and unplanned revascularizations. So that's revascularization in general. And they do give a Class 1A recommendation for one specific territory, and that is diabetes and multi-vessel disease. Then you should consider CABG with a lima to the LAD is preferable to PCI. So we'll talk about the evidence for that. And then there's one carve-out, and that's for patient with LV dysfunction with a Class 1B recommendation that if you've got multi-vessel disease, LVEF less than or equal to 35%, CABG in addition to medical therapy is recommended over medical therapy, and it doesn't say anything about PCI. So what's all of this based on? So first of all, let's start on that first recommendation on improving symptoms. And this is really based on data that in patients who are symptomatic, who need revascularization, we've got randomized trials such as the Syntax trial in triple vessel disease, or left main disease, where you get marked improvements in quality of life with both PCI or CABG. And we can equivocate whether there are small trivial differences between PCI and CABG, but you can see bottom line is you start at 70 and you go up to 90. In the first month, there's a clear benefit in physical limitations with PCI over CABG, but then there's a catch-up with CABG, and with all the other domains, you have, again, marked improvements with both procedures. And we saw the exact same thing in the Excel trial, symptomatic patients, marked improvement with both PCI and with CABG. This first month is a problem for CABG, but then there's a nice catch-up, and you get similar long-term outcomes. All right, so now let's talk about left main disease. Okay, well, shockingly, with CABG and left main disease, everything we think we know about the prognostic benefit was based on 2 randomized trials performed 40 years ago in 150 total patients. We don't even consider that a pilot trial anymore. These were the VA and European cooperative studies, but there was such a marked reduction in 5-year mortality and an improvement in overall, about 20 months overall survival within those 5 years, that CABG became the standard of care to improve survival, despite the fact that there was almost no medical therapy. There were no statins. In fact, a lot of these patients weren't even on aspirin. But nonetheless, CABG became the standard of care. So now everything is compared to that. So now we have the 4 randomized trials of left main drug-eluting stents versus CABG, and you can see overall similar 5-year mortality with the 2 procedures. 2 of the trials have reported data out to 10 years, and actually, if anything, there's a catch-up with the overall all-cause mortality rates becoming closer together at the end of 10 years than 5 years. So very similar mortality after PCI versus CABG in left main disease. And we really have not seen an interaction between diabetes and left main disease in terms of the outcomes of PCI versus CABG. This is from those 4 randomized trials, which again is the best data set that we've got. And you can see diabetics have worse outcomes after both PCI and CABG, but in terms of all-cause death, which is the most important endpoint here, there was no significant difference in 5-year outcomes, mortality, PCI versus CABG, and no interaction, interaction of 0.87. Now, where there may be an interaction in left main disease, and I use the term may, is with anatomic complexity with the syntax score. There's no interaction formally when we tested the 3 tertiles for either all-cause death or cardiac death, but when we did a spline analysis looking at cardiac death, this is the hazard ratio for PCI versus CABG, and you can see up to a syntax score of about 32, that's low and intermediate complexity. There was absolutely similar mortality with PCI and CABG. If anything, the point estimate's slightly lower for PCI. But once you get above 32, and this was a quarter of the patients in these randomized trials, the hazard ratio favoring CABG increases. So when you get to ultimately 45, then this was, even in this modest-sized data set, statistically significant. So I think there's probably something here that in high complexity, this is not the left main itself, this is the other multivessel disease that's present. So left main multivessel disease favors CABG. Now you've got to weigh that off against the difference in stroke. There's about a 1% periprocedural difference in stroke with CABG, and there's a little attenuation over time, but the manuscript calls that out. Now, multivessel disease, the best data set we have for PCI versus CABG is this pooled individual patient data analysis of 8 randomized trials, 7,040 patients, and here you see about a 2.6% difference in mortality, favoring CABG over PCI in multivessel disease. But really, here we do see an interaction with diabetes and multivessel disease, and that's why diabetes was called out. In the higher-risk diabetic patients, there's a 5.5% difference in mortality favoring CABG, where there was no difference in mortality in non-diabetic patients with multivessel disease. And this interaction was much stronger than the anatomic interaction. And you do have to weigh that against, though, the 1% higher risk of stroke in all patients with multivessel disease with CABG compared to PCI. If you look at the most recent FAME-3 trial, which was physiologically guided PCI versus CABG, at 1 year, there was a difference favoring CABG. This was driven by a lot of repeat revascularizations, but again, this brings up the issue of what's the appropriate endpoint, because there are actually more unplanned rehospitalizations for other causes than repeat revascularizations, which is a worse outcome. So if you look at the 5-year outcomes now, just focusing on the more important endpoints of death, stroke, or MI, there was no significant overall differences between PCI and CABG, and this was triple vessel disease patients. So these are complex multivessel disease, triple vessel disease. In fact, the early benefit of CABG was seen at 1 year. There were fewer spontaneous MIs at 1 year. From 1 year to 5 year, the curves were absolutely overlapping. There was no significant interaction with diabetes here, and a weird interaction with syntax score in that there was a better outcomes with CABG and intermediate syntax score, but not with lower high syntax scores. Overall, the interaction was negative. And finally, LV dysfunction, of course, is based on the STITCH trial. It took a total of 1,200 patients, 10 years, to be able to see a difference in mortality. This was an early trial in which there was not great medical therapy given in these patients with LV dysfunction, but CABG reduced mortality compared to medical therapy, with a number needed to treat of only 14 patients to prevent 1 death. So in contrast, the smaller BESIS-2 trial that had about as half a long follow-up showed absolutely no difference in mortality. So from a randomized trial point of view, we can argue and discuss why these results were different. Again, smaller number of patients, half as much follow-up, fewer events, much better medical therapy, lower risk patients, et cetera. There is much larger studies that were propensity-adjusted non-randomized data to suggest that PCI is similar to CABG in terms of mortality, but these are not randomized data. So this is what the guidelines are based on. So the bottom line is that, Mario Gardina and I, one of the leading, academic cardiac surgeons, along with Mike Farku, who led the FREEDOM trial, published a perspective of PCI versus CABG in the European Heart Journal, which was an evidence-based and patient-centered reconciliation, talking about how different, but in many respects, how similar these procedures are. That for many of the patients, the choice is agreed upon by all specialists. CABG is strongly preferred by the heart team when there's very complex anatomic disease. PCI may be strongly preferred if multiple clinical comorbidities are present, such as stroke, lung disease, and frailty. But really, for when there's equipoise and when you can get a good degree of revascularization by both procedures, for most patients, there are not major differences in outcome. There may be 1 or 2% differences, in one outcome or another outcome, but that means that 95 to 98% of the time, it doesn't make a big difference. So you have to consider in these patients a strong patient preference. We're here to serve the patients are not here to serve us. Some patients prefer the short-term advantages of PCI compared to CABG. Some patients prefer the durability that CABG offers compared to PCI, and we have to be honest and not let them know that in this, quote, so-called competition, there are huge differences between the outcomes of the procedures, when in most cases, they're really relatively small. Thanks very much.
Thank you. So we're going to move next talk quickly. David Paul Taggart will give us a CABG is still standard choice of main and multivessel disease, please.
Thank you, Mr. Chairman. Good morning, everyone. It's always very difficult to follow Dr. Gregg Stone because his understanding and knowledge and presentation of data is almost unmatched, but I'll try. So I'm going to talk about why CABG is still the standard choice for left main and multivessel disease. To do this in 8 minutes is very difficult. So what I'm going to largely do is concentrate on left main disease because I talked about multivessel disease yesterday. I don't have any significant conflicts of interest relevant to this talk, except I was one of the originally main contributors to the Excel trial, but withdrew my name from the final publication. This is a paper we published in 2008, suggesting why CABG was a standard therapy for most patients with left main disease. We pointed out that up to 90% of these patients will have multivessel disease, where CABG already has a survival advantage independent of left main disease, and up to 90% of left mains have distal or bifurcation lesions are at much higher risk of restenosis. We also pointed out, however, that for patients with isolated osseal or mid-shaft left lesions, the outcomes were superb for PCI and possibly even better than for CABG. This is a seminal work from Dr. S.J. Park and his colleagues in Asan, showing the benefits or potential benefits of stents in left main disease, and they concluded PCI with bare metal stents or drug-eluting stents led to non-significant increased hazard ratio for death and composites of death, MI, and stroke, and much greater target vessel revascularization. And this was the premise for starting the first true randomized trial of PCI and CABG, which was the pre-combat trial of 600 patients. In the meantime, the outcomes were published of what happened in left main disease from the Syntax trial, published almost a decade now, and it showed a very distinct difference between patients with left main who had MACE risk scores of Syntax scores of 0 to 32, where there was no difference between PCI and CABG, but for those with Syntax scores above 33, there was a very clear survival advantage for CABG patients. And this is a number of important implications. It showed the accelerating benefits of CABG over time for those with high Syntax scores. It was used to define the patients who were entered into the Excel trial, mainly patients with Syntax scores below 33. And it raised the question of why did CABG patients not do well with lower Syntax scores? And the probable answer is that without proximal coronary artery disease, there is too much competitive flow. So this led to the landmark publication in 2019 of the Excel trial, and I still argue the Excel trial is the most important trial ever of left main disease. It was the largest, most definitive trial, although one has to say it had selected patients with Syntax scores below 33, which would realistically account for about 1/3 of patients in routine clinical practice. 1,905 patients were randomized, but enrollment was stopped early. The mean age of these patients was 66, which means they should have, if treated properly, a life expectancy of 15 to 20 years. The primary outcome was different from conventional trials. It was a composite of death, MI, and stroke, but not repeat revascularization. And in contrast to other trials, it used a new biochemical definition of MI, but did not include the universal defined definition of myocardial infarction. And I have to say, I'm very proud to come from Oxford, where we, the surgeons and the cardiologists, were the second largest recruiters to this trial in the world. If you look at what happened at 5 years, there seemed to be an increasing and accelerating mortality difference between PCI and CABG at 5 years. And if you bear in mind these were patients who were relatively young, with a mean age of 66 years, a relatively low Syntax score, on average less than 33, the overall mean Syntax score was 26, and for PCI, the increase in death in relative terms was almost 40%. I will show you there was an increase in non-procedural MI and an increase in repeat revascularization. The conclusions of the Excel trial, and I would specifically refer to this as the most definitive trial of PCI and CABG, said in patients with left main coronary disease of low or intermediate anatomical complexity, there was no significant difference between PCI and CABG with respect to the rate of the composite outcome of death, stroke, or MI at 5 years. As one of the initial authors of this paper, I disagreed with that conclusion and withdrew my name. If we look at what happened between the biochemical definition of MI in the Excel trial and the third universal definition of MI, which allowed you to compare Excel with every other trial, you can see that the biochemical definition strongly favored PCI, whereas the universal definition of MI strongly favoured CABG. And had that been interpreted as such, it would have changed the primary outcome of the Excel trial. The Noble trial, another trial of left main with PCI and CABG, they had a lower syntax score compared to CABG. I'm sorry, compared to Excel. And if you look in their results, the mortality difference was in favour of CABG, but did not reach statistical significance. But it did show a strong reduction in myocardial infarction, repeat revascularization, and interestingly, it showed that risk of stroke was higher in the PCI group, and most investigators would say this was a statistical fluke and not a realistic observation. If we look at what happened after Excel, there were numerous meta-analyses trying to override the results of Excel in favour of no difference. This is the most quoted paper. It was an individual patient data meta-analysis, 4 randomized trials, over 4,000 patients, including syntax, pre-combat, Noble, Excel. What's very important to note is the median syntax score in these trials was 25. So that's identical to what syntax showed, that in patients with low syntax scores, there was no difference between PCI and CABG in terms of survival. But it doesn't represent real clinical practice. 2/3 of patients in real clinical practice have syntax scores above 32. So while this meta-analysis showed no difference in the instances of death, it still showed that for CABG, even as early as 5 years, very highly significant reduction in the incidence of spontaneous MI, repeat revascularization, and no difference in the incidence of stroke. So I would say that what is confusing about this paper is the manuscript title gives no indication that the results apply to approximately 1/3 of patients in real clinical practice, and it should have said selected left main. It was presented as applying to all patients with left main, and I would argue as such it is dangerous. It was consistent with what syntax showed, which was patients with syntax scores above 33 were far better off with CABG. This is the 10-year outcomes of Dr. Park's study, the pre-combat study, showing no differences in 10-year outcomes in patients with a mean syntax score of 25, but also in his very important main compare registry, he's pointed out the difference between patients who had ostial or shaft disease compared to those with distal or bifurcation lesions. And what it showed very clearly was that if you had a distal or bifurcation lesion, it significantly increased your mortality, your risk of MACE, and the risk of repeat revascularization at 5 years. So I'm running out of time, so I'm going to stop here. I unfortunately don't have time to discuss multi-vessel disease, but I would again like to say to the organizers, Dr. Park, both SJ and Duck Wu, and the rest of the organizers for the invitation to be at this meeting. And it's particularly honorable considering this is the 30th anniversary of TCTAP. I'm delighted to be here and very honored to have this opportunity to talk to the audience. Thank you.
Short
Okay, I will introduce the next speaker. That's what it is. Okay. So we have the pleasure to have Sripal Bangalore, and his topic is complete revascularization clinical practice, ACS or stable CAD, or for both.
Thank you. Thank you very much. So I'm going to make a case. Let's look at evidence base for complete revascularization. What should we be doing in 2025? So these are some of my disclosures as it relates to this particular talk. So the fundamental question is, can complete revascularization improve outcomes? And specifically, we look at patients with STEMI, we look at patients with NSTEMI, specifically also diving into patients with cardiogenic shock, and finally patients with chronic coronary disease. Starting with patients with STEMI, now we have more than 15 randomized trials, but one of the biggest randomized trial was the complete trial, over 4,000 patients with STEMI and multivessel disease. Complete revascularization was achieved in 90% of patients, and clearly, when compared to culprit-only revascularization, complete revascularization was linked with a significant reduction in CV death or MI. There was a reduction in MI and also unstable angina. So there have been a number of meta-analyses. This is one of them, looking at 10 randomized trials, 7,000 patients, STEMI and multivessel disease. There was not only a reduction in CV death or MI, but if you look at individual endpoints, CV death, there was a 31% reduction. There was also a reduction in MI, a 32% reduction. We recently published this network meta-analysis of randomized trials, 16 randomized trials, 12,000 patients. And the question we asked here was not just the question whether complete revascularization is better, but what is the timing of complete revascularization? Should it be at the same setting, or should it be stage complete when compared to culprit-only revascularization? So these are some of the outcomes. If you look at CV death or MI, both single setting complete and stage complete significantly reduced this endpoint, but there was greater benefit with single setting complete revascularization. There is no significant difference in death. And if you look at MI, again, both single setting and stage complete significantly reduced MI with greater benefit with the single setting complete revascularization. Of course, I mean, these results are applicable to patients enrolled in these trials, and typically these tended to be less complex, very low proportion of patients with CTOs. And the way I look at single setting complete is, if you haven't spent a lot of time or contrast or radiation with your complete revascularization, you can go ahead and do complete revascularization in the same setting. So we concluded here by stating single-setting complete revascularization may offer the greatest reduction in cardiovascular events in patients with acute MI and multivessel disease. The 2025 ACC/AHA ACS guidelines also cover this, and it's now a Class 2B indication to completely revascularize in the same setting in patients with ACS. Let's move on. What about patients with NSTEMI? Is there data to support complete revascularization in this setting? So the FIRE trial, 1,400 elderly patients, 2/3 of them had NSTEMI. They were randomized to complete versus culprit only. And again, you can see complete revascularization, significant reduction in cardiovascular endpoints, including a reduction in CV death or MI. In this trial, you can see there was a significant reduction in all-cause death, the cardiovascular death, in addition to MI and ischemia-driven revascularization. And if you look at the interaction between STEMI and NSTEMI, there was no significant interaction, suggesting similar benefits of complete revascularization both in the STEMI and the NSTEMI setting. What about patients with cardiogenic shock? The culprit shock trial addressed this question, 600 patients with MI and cardiogenic shock with multivessel coronary disease. And in this trial, multivessel PCI was associated with significant increase in the risk of death or renal replacement when compared to culprit-only revascularization. And the difference was also driven by significant increase in the risk of death. What about finally patients with chronic coronary disease? There have been a number of observational studies which have looked at complete versus incomplete revascularization in the setting of stable coronary disease. These are some of the analyses from the ischemia trial. Gregg led one of these, looking at complete revascularization in ischemia trial, looking at cardiovascular endpoints. And these are some of the results from ischemia. So you can see in terms of anatomic complete revascularization, this was achieved in around 43% of patients. The functional complete revascularization was in 58% of patients. And if you look at the clinical outcomes, the complete revascularization curves are in blue. The conservative strategy is in black, and the red is in patients who are randomized to invasive and they were incompletely revascularized. And clearly you can see there is a greater benefit of the invasive strategy if the patients were completely revascularized when compared to conservative strategy for the endpoint of CV death or MI, driven mainly by a significant difference in MI. So we concluded by stating that the outcomes of an invasive strategy may be improved if complete revascularization, especially anatomic complete revascularization, is achieved. What about quality of life? So this is our analysis looking at quality of life in ischemia trial based on completeness of revascularization. And the story is very similar that if patients in the invasive strategy had anatomic complete revascularization, there was a greater quality of life benefit, greater freedom from angina when compared to conservative strategy. So we concluded by stating that among patients with chronic coronary disease and ischemia, health status improved more frequently, more with complete revascularization compared to incomplete revascularization or conservative strategy, particularly in those with frequent angina. And finally, we heard a lot in the first two talks about PCI and CABG. The question is, can we actually bridge the gap between PCI and CABG with complete revascularization? Is the missing link between PCI and CABG completeness of revascularization? So we published this data from New York State Angioplasty Registry looking at everolimus-eluting stents or bypass surgery for multivessel coronary disease, where we showed this is 18,000 propensity-matched patients. We showed that no significant difference in death between PCI and CABG. CABG was associated with significant increase in stroke when compared to PCI, whereas PCI was associated with significant increase in MI when compared to CABG. We then looked at completeness of revascularization to understand whether the differences in MI is driven by completeness of revasc. And we showed that there was a significant interaction such that if you can completely revascularize with PCI, there is no significant difference in MI between PCI and CABG. And most of the differences were driven by incomplete revascularization with PCI. Then now going back to what is the achievement of completeness of revascularization. So these are the percentage of patients who achieve completeness of revascularization in randomized trials. So anywhere between 40 to 50%. What are we doing in real world? So this is some of the data, including one of my publications from the New York Registry. We do even worse. Only 30% of patients in real world are getting complete revascularization. And of course, this leads us to the question, is it okay to, is there a reasonably incomplete revascularization select group of patients, especially patients who have small vessel disease, diffuse disease, maybe patients where the territory is non-viable. And if you look at the guidelines, it's a 2025 ACCHA guidelines for STEMI. Complete revascularization is class 1. NSTEMI, it's class 1. And if you have cardiogenic shock, routine complete revascularization is a class 3 indication. So in conclusion, evidence from a randomized trial in both STEMI and NSTEMI suggests a significant reduction in cardiovascular events, no major difference in death with complete revascularization. For ACS without shock, it's therefore a class 1 indication to complete revasc. And patients with shock, it's a class 3 indication. Evidence from non-randomized trials points to a similar signal in patients with stable CAD, but randomized trials are lacking. Given the totality of data, optimal revascularization in 2025 should aim for complete revascularization when safely possible, unless there are patient and anatomic factors that preclude it. Thank you for your attention.
Yeah, okay, so we will continue. So the next speaker is Akiko Maehara, Mechanism of Left Main Stent Failure. Akiko.
Thank you. So this title is a little bit misleading. We're picking up the stenosis in the distal left main. So some of the lesion is actually proximal LAD osteal stent, but at the time of the stenosis, that's causing the left main stenosis. Those are the cohort. So this is one of the example. You see the circumflex having the old stent, and that's up to the ostium. LAD, there is a stent in the mid segment, but no stent in the proximal segment. And left main, no stent. But at the time of the stenosis, this is obviously already left main stenosis. So we see this type of the stenosis quite often. And what's happening? This picture is really, I'm surprised. What's happening? This is after 2.5 balloon. And when we look into the circumflex, all the stent was okay expansion. And you see the neointimal hyperplasia, this is after the balloon. And that neointimal hyperplasia is actually extended to the left domain. This is, I do think this is neointimal hyperplasia on top of the calcified plaque, here and here. On top, on the LED, I see the similar pattern of the tissue, which I would think that's a neointimal hyperplasia. So even though this is a stent up to the circumflex ostium, looks like neointima from the circumflex ostium extended to the left domain as well as the LED ostium is causing this type of the stenosis. So this is the overall study population. We start from the about 12 years data from Colombia, and we're picking up only the left domain stenosis cases. And as I said, some of them could be like circumflex osteostenting. And we found 86 left domain stent stenosis, IVUS guidance PCI. And this is a patient population, and about 70 years old, and majority was male. And prior CABG is about 30%, and CKD is about 50%. And EF is 47%, and years from the index PCI is 4.4 years. And interestingly, the majority of the presentation at the time of the in-stent stenosis is actually ACS. And the medication at the time of the in-stent stenosis, and the majority of the patient having the DAPT or stitching therapy. And this is how it looks like the procedure at the time of the index procedure. So 30% of the cases actually only the osteo-LED stent, and 40% of the stent was only the osteocircumflex. And other is two stent technique is 25%, and the single stent technique is 74%. And from the LED to the left domain, or circumflex to left domain, or left domain body only, which is very, very rare. And when we look into the procedure at the time of the index, at the time of the in-stent stenosis, the cutting balloon, scoring balloon, or most likely done by the non-compliant balloon. And the final treatment is half of the cases having the new stent implantation. But this is before the coating balloon is available in the United States. The majority of the cases was done based on the just balloon angioplasty only. And first, this is a diagnostic accuracy compared to the angio and the IVUS. And you can see the left domain or osteo-LED, they are poor negative predictive value. So if you think, I don't see any issue in the LED or left domain, but actually there is an issue. But on the other hand, circumflex is much better negative predictive value. So I think when we look into the distal left domain bifurcation region, accuracy is very different, and especially we have to be very careful of the LED and the left domain stenosis extension. And this is the overall mechanism of the in-stent stenosis. We considered under expansion of the left domain is less than 6, and LED or circumflex is less than 4. So under expansion is very rare because majority of the stent was implanted by IVUS guidance. And you can see that most of the issue was due to the neointimal hyperplasia, and if that is all, that's neoatherosclerosis. But interestingly, when we look into the either POC, meaning bifurcation or left domain, the cause is much more variation, meaning stent fracture or the calcified nodule protruding through the stent. Those are the more variation compared to the LED ostium or circumflex ostium. And this is IVUS findings. There is a lot, but I think the key findings was this cohort is stent expansion was good. So all the stent, minimum stent area, is each segment was not too bad. And the calcified nodule is very frequent in the left domain POC. And as I show in the first picture, like proliferating the neointima into the other segment is actually frequent as well. Probably this is the most striking data. And when we look into the outcome after the in-stent stenosis treatment involving the distal left domain by PCI, and it's bad. And because of the half of the cases, there is no stent, those are the bad, that could be improved by using the drug coating balloon. But even the new stent implantation cohort, half of the patient at 3 years, they have additional event. So that's the reason why we have poor outcome after the stenosis of the left domain stenting. And we ask what is associated independent factor to associate long-term outcome? And that's the CKD as well as a new stent technique. New stent implantation is actually better compared to without. So those are the independent predictor. So This is retrospective data, and I would emphasize this is very biased cohort, but I think this is telling us, number one, intravascular imaging clarify the cause of left main stent stenosis, and when we look into the dose segment, LAD ostium and left main is poor diagnosis accuracy by angio. It's really important to review by intravascular imaging. And those cohort is neointimaplasia is key contributor of the left main stent stenosis, and interestingly, proliferating neointima into the other segment that's causing the stenosis as well. And most strikingly, event rate is about 50% at 3 years. But in patients with left main stent stenosis, new stent or drug-coating balloon could improve the outcome. But I think still 50% even new stent technique. So that's a reason we discuss a lot. Who should be stented in the left main? So those are the data, what's happening after the stent stenosis. Thank you.
Okay. As a next two talk is we've really arranged the order of talk, and so Dr. Jung-Min Ahn from Assam Medical Center will give us IVUS guided main bifurcation treatment, please.
Thank you, SJ. I am Jung-Min Ahn from Assam Medical Centers. So what we know is that IVUS guided left main PCI is associated with a lower mortality rate in our main compare registry. In addition, the bifurcation randomized trial, October trial, showed that when you use the OCT to the treatment of bifurcation, decrease the risk of event, even in the left main bifurcation. So 2024, 2025 American European guideline consider the 1A indication for left main IVUS guidance. But we don't know is how to guide the left main treatment strategy, one stent crossover or bifurcation stenting. We have two randomized trial, literally same inclusion criteria, angiographic inclusion criteria, two protective bifurcation left main coronary artery disease. But the one random trial, DK Crush 5, favored the DK Crush stenting, upfront two stent technique. The other study, EBC main, favored the one stent crossover. Why? So I think literally the same angiographic criteria, but the true complexity of left main would be different. Look at in detail the provisional group. Finally 47% of patients in DK Crush provisional group finally performed the two stent technique. And EBC main trial in provisional group, 22% of patients finally performed the two stents. So 47%, 22%. I think the complexity of left main would be different. So why? I think that this is due to the angiographic evaluation of left main bifurcation. We have only one the criteria to guide the simple crossover or upfront two stent technique. This is the definition criteria by the Xiaoring Chen groups. So major criteria is left main lesion length and diameter stenosis. 10 millimeters and 70%. But as you know, angiographic diagnosis is not reproducible, sometimes inaccurate. So usually, conventionally in our centers, we evaluated the IVUS, circumflex ostial disease by IVUS, determine the strategy. Here is a two tight stenosis of distal left main. When you look at in detail to the circumflex ostium, upper panel, very large plaque, small lumen, lower panel, very normal-looking circumflex ostium. So upper panel, we can treat it by the two-stent technique, and lower panel, the single crossover stenting. In addition, when you look at the IVUS, you can measure it. So we can have the objective number. So I'd like to introduce our imaging-based decision criteria for left main bifurcation treatment. So most important decision would be which is left main treated preferred provisional stenting or two-stent technique, and how to optimize the stent result. So based on the 278 left main provisional stenting patient, all these patients have pre-procedural circumflex ostium IVUS findings and compare the two-stent patient. We look at the minimal lumen area and plaque burden in provisional stenting group compared with the two stenting group. Minimal lumen area is smaller and minimal lumen area is larger and plaque burden is smaller. So after simple crossover stenting, among the 278 patients, 60.8% of patients suffered from acute procedural complication, including beta stenting, kissing balloon, POBA, FFR is lower than 0.80, something like that. So to predict the acute procedural complication, minimal lumen area plaque burden criteria was 3.7 and 64% of plaque burden. Interestingly, this is very similar to the previous Dr. Kang's data, the predictor of to predict the functional significant circumflex jailing after simple crossover stenting. Circumflex ostia, the minimal lumen area 3.7, plaque burden is 56. So according to, if there is some combination of small lumen, large plaque burden, acute procedural complication is up to 31%. So 1 out of 3 patients after simple crossover stenting, operator have to do something more for the circumflex ostium. When we evaluated the 5-year follow, this one stent high-risk group, combination of high plaque burden, small lumen, numerically higher than 2 stent very expanded groups. So I suggest that such groups, if these groups upfront the 2 stent technique, we can reduce the risk of clinical risk. We can reduce the clinical risk like 10% from the 14% to 10% at 5-year follow. So I'd like to suggest that the minimum lumen area 3.7, plaque burden more than 64. If there is some combination of these findings, upfront 2 stent technique would be better, and other cases simple crossover stenting would be better. Many stent technique, bifurcation stent technique. So I think the selection of any kind of simple bifurcation technique, I think stent optimization is more important for the future patient prognosis. Conventionally, we have a very popular numbers, 5, 6, 7, 8, but this number is validated against the 9-month instant restenosis. So recently, we evaluated the new optimizing MSA criteria against the 5-year clinical outcome data. For the 2 stent crush technique population, we evaluated the distal leg main, proximal LAD, circumflex ostium. We found that the distal leg main cutoff criteria is 11.8, but unfortunately, distal leg main MSA was not associated with MACE at 5 years. But LAD ostium and circumflex ostium, LAD ostium 8.3, circumflex ostium 5.7, very significantly associated with the 5-year MACE. If there is under-expansion in both LAD and circumflex, event rate is very high, 23%. But other groups, event rate at 5 years is only the 5 and 6%, 1% per year, even in patients with this left main bifurcation treated by 2 stent technique. And how to optimize the provisional stenting, we analyzed the same analysis, distal proximal left main, distal left main, LAD ostium. We found that the proximal left main 11.4, distal left main 8.4, the proximal LAD 8.1. All these cutoff value was significantly associated with the 5-year outcomes. Similarly, 2 segment under expansion is a significantly high event rate at 5 years, but 1 segment under expansion, low under expansion, it showed better clinical outcomes. This is our new imaging algorithm for the left main treatment. Please look at the circumflex ostium by imaging, IVUS or OCT. If there is some high-risk combination, high plaque burden, small lumen, no, provisional stenting would be preferred. Yes, I think the upfront 2 stent technique would be preferred to avoid the acute procedural complication. After any kind of bifurcation stenting, please optimization of your stent by high pressure balloon according to our MSA criteria. Thank you for your attention.
Great. Next talk. Actually, Dr. Do-Yoon Kang will be a little bit late, and so we're going to have some discussion time first, and we're going to have a talk, okay? David, Akiko, any talk? Any?
Yes, as a non-expert cardiologist, to me, the thing that strikes me most about left main disease is I think it occurs in two categories. I think if it's osteo or mid-shaft, I think that's aortic disease. I think if it's distal bifurcation, especially with the addition of proximal coronary artery disease, is a very different disease.
Last speaker is not coming. Okay. So, yeah, I think that many years ago we were in a debate, you remember, and I think that the field has moved quite intensively.
Yes.
So I think today, if I have to think about the main stem, I will agree with you that it's a different animal from the three-vessel disease.
Yes.
That's the first statement.
Right. Yeah.
The second statement is that main stem without three-vessel disease
Yes.
is not so frequent.
Right.
Correct.
That's the
Yeah.
second thing.
Yeah.
I think in terms of trials, Greg Stone and Mario Godino are showing the way. I think that in the future we have to do trial with extremely long follow-up.
Yes.
5 years, 10 years.
Yeah.
That's what they are going to do in discharge. And then at the end of the day, if you take the position of the patient, you are yourself a patient, you want to be alive in 10 years, and you want to have a good quality of life. You know, the troponin, the CABG, even the reintervention for something complementary is not so relevant. As long as you are alive 10 years later and you can play golf, you are a happy man. So quality is finally something which is becoming much more relevant. I even believe that the enzyme will disappear at some point, you know, the super high sensitivity and say. What I miss this morning is secondary prevention. That's amazing, not a single word about secondary prevention. You know, we published the 10 years follow-up of the randomized trial plus the registry, because that was the point of Frederick Moore's. I will not participate in a trial with cherry picking.
Yes.
So the syntax trial is really a trial with 4,000 screening, 1,200 registry, and 1,800 randomized. In that trial, starting in 2005, we have almost a Mendelian randomization, statin versus non-statin. The patient with statin, 10 years later, have a mortality of 19%. The patient without statin, 10 years later, has a mortality of 32%. So why in a meeting of interventional cardiologists, there is not a single word on secondary prevention? That's the three remarks that I would do. Finally, you know, when we had this debate with Excel, and we were all very much emotionally involved in that debate, I think that the only solution that I could see with the surgeon is to give all the material to the group of Gene Braunwald, to the TIMI group. And I think that what they found is, for me at least, very pleasant and relevant, is that the hazard ratio for mortality is the same in these 4 trials up to 33. And at 33, it jumps.
It changes,
So I think that's the 4 message relate to your presentation that I think is important. But I would like to hear SJ and the rest of the panel, because that's just my assessment today.
I agree.
But one final word. In the trial that we do now on three-vessel disease, do you know what is the percentage of the patient who get below 55 milligram of LDL? What is your guess?
less than 20%.
LDL.
I'll let not hesitate.
right.
15%.
All right.
15% of the patient are below the 55 milligram. And you know, in stent restenosis, that's also part of it.
Oh, great insight. Really, Patrick always give us a, very, comprehensive insight for us. And anyways, that session is regarding the main and multivessel disease, right? However, just Patrick mentioned about it. The main issue is, I think, is multivessels. Isolated main disease in the ostial shaft disease, even without concomitant multivessel, three-vessel disease, isolated main bifurcation disease also is not a big deal. The meaning is, all the prognosis and procedural outcome for the main disease mainly depending on the multivessel disease status, complexity, syntax score, anatomic complexity, high syntax score, usually included more high incidence of two-vessel disease, three-vessel disease.
Yeah.
So what I'm thinking is just, all right, today the technical issues we want to discuss later. However, conceptually, even in the main disease, guideline concern is more generous in terms of, PCI, or something like that.
I see a lot of microphone red. Maybe Mamas was the first.
So thank you. I think David made a really important point, and the important point that I wanted to discuss further was, what is the life expectancy of these patients? It's between 15 and 20 years. And so to my mind, we have to move away from thinking about PCI versus CABG and think about the lifetime revascularization of these patients. I think personally, for low-risk patients with isolated left main, go for PCI. I think then as patients progress in their coronary disease, and the coronary disease will progress, that's when you use CABG, because that's where the prognostic impact is. If you do CABG too early on, then often these patients where grafts fail, and we know from European data, 15, 20 years down the line, they will fail. It's very difficult to do PCI. You end up having to do crazy CTOs and so forth. So think about the lifetime management.
I think AJ made a very important point. It's not the left main per se. It's the associated triple vessel disease that makes an impact. Because syntax score by isolated left main is low. I mean, even if you have restenosis of the circumflex, as long as you don't do angiographic follow-up, nothing happens. The restenosis of the circumflex is unconsequential. It's only triggered by angiographic follow-up.
Two additional quick comments on this is that one, in line with Patrick's comments, I think that if we repeated Excel today, I'm not sure that we would find a different result. And there are opportunities that we could improve outcomes with intravascular imaging on the interventional side. CABG, certainly cohorts typically have inferior rates of medical management post-surgery in our clinical trials, but the application of it in real-world clinical practice has been disappointing. The second issue, though, is this emphasis on quality of life, that I don't think we've characterized this well enough in our clinical trials, and I don't think in an era of shared decision-making, we've employed enough insight or trials into looking at patient preference in these opportunities as well. The heart team approach is very varied across centers, but really to pose to patients the benefits and risks, not only with regard to the hard endpoints, but the peri-procedural complications, their time to recovery, perhaps their long-term avoidance of myocardial infarction or repeat revascularization, all needs to be balanced, and we don't have good patient perspectives on that like a discrete choice experiment could inform.
I would agree with that, but I mean, in the good old days when Harry Peter Capitaine was seeing the patient before me and I was seeing the patient after, we came with totally different arguments. So I said, we stop to do these things. Yeah. We'll go together to see the patient. And when we were together with the patient, the dialogue was quite different because all the element of preference, do I really care about a few more days in the hospital if 10 years later I'm okay, survival and playing golf? No, you forgot all that. It's amazing how the surgical patient forgot all the miseries that they have seen at the time of surgery, you know, just because it's part of it, but long-term is the very important thing.
Yeah,
I have
this
to
is
say-
why objectively presenting it to the patient and letting the patient see in front of him or her what those balances are without being influenced by the interventionalist or the surgeon would be of help.
In the UK and
Let me say something about that. You know what the patient usually say when he see the two doctors, the interventional cardiologist and the surgeon? I don't know. What are you advising, doctor?
Yeah.
That was the final word most of the time.
In the UK and most of Northern Europe, but not Southern Europe, we're the only part of the world that have genuine heart teams for coronary artery disease as well as structural heart disease. And I can tell you, in my experience, and ask this to anyone, if you go to a patient and say, you're recommending a decision based on a team of expert doctors from the heart team who recommend why they should have CABG to prolong their life over 20 years. It's incredibly unusual in the UK for a patient to say, I'm not going to follow your advice. It's all to do with the way the information is presented to the patient. And there are very few people in this room, if you said, I can offer you two options. One is stenting of your coronary artery disease, but your 5-year survival, never mind 20-year survival, will not be as good as a CABG operation. The vast majority of patients, if that's explained to them, would accept CABG.
So what you are telling us that what the so-called preference argument is not fully informed.
Correct. Absolutely correct.
Okay, so from the audience, right?
Thank you, Prof. Park. So I think when we are talking about the optimization of the left main intervention, the problem is when we are facing the huge discrepancy between the left main and the LAD, let's say. So when we do the provisional stenting, the initial recommendation always follow the distal vessel size and then post-dilate doing both based on the left main vessel diameter, correct? So the latest recommendation I just heard from Dr. Koran a few weeks ago, that kind of technique may, create stent deformation at the polygon of confluence. So the latest recommendation actually upsize the distal segment of the stent, one size bigger, and then make it better. Any comment regarding that issue?
Maybe Akiko and Do-Yoon can answer that question of that comment. No, they are not. Akiko.
I see I heard that's kind of a concept, but reality, we do always based on the distal, and I don't see acutely so often the deformation. But that concept, I think they are talking more, yeah, that's my opinion.
Okay, Dr. Do-Yoon, all right, Gregg, all right.
You take the microphone and give an answer, and then we'll go to Gregg Stone, yeah?
So, I do agree with David that it's very important how we talk to our patients. A lot of patients don't have a sophisticated knowledge of these concepts like we do. And if the patient hears, you're going to live with one procedure and die with another procedure, they hear it one way, right? If you just say, one procedure's got better survival than the other procedure, that's actually not an accurate way to present the differences. So Paul Tierstein wrote a very interesting editorial, and he said in California, he goes, even if the Excel results were accurate, and there's a 3% absolute difference in mortality at the end of 5 years, 0.6% per year. And he goes, he tells his patients, here's a deck of 33 cards, okay? If you choose one bad card, you may not be alive if you have PCI versus CABG, at the end of 5-year period. Now which procedure do you want? And he goes, not a single patient would ever choose CABG if he presents it that way. So this, when we did before Recharge, as Patrick was talking about, we did semi-structured interviews and focus groups with 40 different patient organizations. And no patient told us that they care about small differences in survival. Not a single patient told us that. They told us they want to be with their families, they want to live a good, long, happy life. And that's why we designed Recharge to try to give the patients what they want. We are prioritizing survival to the extent that there is a difference in survival in these high-risk patient populations, but we really believe it's time to emphasize not troponin elevations, not small strokes, not peri-procedural MIs or troponin elevations that are spontaneous MIs or a repeat procedure like having your teeth cleaned. But overall, how's the patient doing long-term who had coronary disease, and now we're trying to manage it with the 2 procedures and to see if there's a difference. So we're trying to put it back to what the patients want as opposed to what we want.
You know,
Greg, I completely agree with you, but I have to make one comment. In Excel, these were young patients with an anticipated life expectancy of 15 to 20 years. And at 5 years, there appeared to be not only a significant difference in mortality, but it was accelerating. The implication was, if you had followed these patients for longer, that mortality benefit of CABG at 5 years would have been even greater. Look at the survival curves. So to me, I would say to you, as Dr. Serruys has written about the Syntax trial, when we're advising patients what to do, the most important thing is to think of what is their expected longevity. And if you've got a young patient with an expected life expectancy of 20 years, a survival difference that's accelerating at 5 years may be much greater at 10 or 20 years.
Thank you.
Well, just let me respond quickly. So, of course, that's an important consideration. And as much as I appreciate your comments on how important the Excel trial was, which I, from a biased point of view, agree with, you have to look at the totality of the data. And when you look at all of the data, there's no difference in mortality after 5 years. And between 5 and 10 years, the curves converge. They don't keep accelerating. The small difference at 5 years that were present in Syntax and pre-combat actually converge at 10 years.
Okay, thank you.
But, you know, all this discussion is interesting, but at the end of the day, the decision is made on the patient that you have in front of you.
Yes.
The type of left main, the associated diffuse disease of the LAD, the right coronary artery is open, is closed, can I open the right or not, the quality of surgery in your hospital. Very few people are willing to transfer the patient to another hospital where they have a better surgeon. So, I mean, all these things are interesting, but the final decision is made from the patient in front of you, the type of disease.
You know, the heart team is 1A, but I can tell you what is the next step. 1A, the need to inform your patient in a balanced way.
Yes.
That will be much and more difficult with time. Andre, you want to say something?
Yeah, because I remember this discussion for 20 years, and one thing what I really want to say is that I absolutely agree with so many points, but what you says about secondary prevention, it's even more wider. This is actually environment. This is precision medicine. It's not so important how we do technically things. It's really important how it works in whole system. And actually, because we can change, and I really like what you said, and all of you says, that we should look on patient for 20 years. What is about follow-ups? What the GPs are there? And now we have, Roxana showed us, so many new drugs are on board, and I guess it is so important.
Thank you. Really, you may not see that anywhere, any conference, this kind of, legendary, renowned expert, getting together, and this discussion is really thank you for that. And however, last talk, just 5 minutes, I would like to introduce Do-Yoon Kang at Asan Medical Center, and he's from United States for this 5-minute lectures, and I will introduce how to manage left main ISL, TCB, DES, and or bypass surgery. Dr. Bang, please.
Yeah, thank you, Dr. Park, and sorry for interrupting those hot discussion. And I will talk briefly how to manage left main ISR. I would skip the case. And there are some limited evidence of the left main ISR. That was all I could find, and the number of the ISR cases was less than 100. And the incidence of the left main ISR in routine angiographic follow-up, the era was about 15% to 20%, and without doing the routine angiographic follow-up, the left main ISR incidence was 10 to 20% by the studies. And in recent, our Center Asa Medical Center data, it was 8.4% on the 7-year of clinical follow-up. And the recent IBD meta-analysis of the syntax precumbent novel and XL showed that all-cause mortality is kept this talk, and but RR was the higher in the PCI group. And the time of the left main ISR from the merged data of the main compare and iris left main, it was 10.8%, and the most frequently in the 1.5 year after the procedure. And the clinical presentation was usually the stable condition in a half of the patient, and another half of the patient has unstable angina, and the acute myocardial infarction was rare. And the angiographic presentation showed that the focal ISR in most cases. However, in clinically driven follow-up CABG patient, the more diffuse patient was shown. And in angiographic finding for the left main ISR in pre-combat 2, the most location of the ISR was the circumflex ostium. The side branch ostium is the Achilles heel of the left main stenting. Yeah, that was the question, the case I would show. And the treatment of the left main ISR for the previous studies showed that the most of the cases was treated with a PCI, and only 10 to 15% of the patient was initially treated with the left main, the CABG. And in the main compare iris main treatment, the registry, among 118 patients experienced left main TLR, the 80% of the patients underwent PCI, and among that, about 30% of the patient experienced the second PCI, and then among them, very rare patient underwent third procedure. And the patient underwent CABG for the first TLR did not experience more a TLR event. And the clinical outcome is various among the studies. And our recent data that shows that the impact of the left main TLR on long-term clinical outcome was not significant compared with the patient that did not experience the TLR. The cardiac death and all-cause mortality was similar between groups, even the patient underwent one TLR for left main. And when we did a more subgroup analysis, the clinical outcome for the left main TLR with the CABG and PCI was similar between groups. And the PCI strategy, the DES and balloon angioplasty and DCB did not, in group, the balloon angioplasty group showed the poor outcome, and the DB and the DES group showed a similar clinical outcome. TLR rate was similar between groups. And the recent ISARA data, by underlying stent technique and by type of the RR, PCI or stenting was the grafting, there was no big difference between groups. So my solution for this patient was the drug-coated balloon to avoid additional metal ratio at the left main with the big side branch. And usually for the first time TLR, I thought that we can treat one more time with the PCI without bad clinical outcome. And then after the second TLR or third TLR, and we have another option with the surgery. So this is my suggestion with the treatment to treat the left main ISR. I use the DCB for ISR and consider DS for de novo side branch disease to cover the new disease, and the careful clinical follow-up with asking the patient's symptom with a tight control of the CV risk factors after left main TLR PCI. And CABG is recommended for recurrent ISR. And prevention is better than treatment. As Dr. Akiko, Maehara, and Dr. Ahn said, intravascular imaging guided optimization during the index PCI can minimize left main ISR. Thank you for your attention.
Thank you. So we're a little bit beyond the schedule, and so really thank you again for active talk, active discussion, Patrick. All right. Thank you. And later, so we're going to see that.